Right, welcome everybody to this AOP webinar. This is the next in our series of monthly events that we've designed to be an informative and thought-provoking forum for expert discussion in the realms of clinical academic medicine. So I'm Sara Brown, I'm Professor of Dermatology and a Wellcome Trust Senior Research Fellow at the University of Edinburgh. The topic this evening is titled Inflammation Crossing the Disciplines. And we have three expert speakers with different perspectives on multisystem inflammation to discuss what we can learn to improve the recognition, treatment and prevention of inflammatory disease. So we've invited the best speakers to give really challenging short talks. They only get 10 minutes. This is to set the scene and promote discussion, because the aim of this is to promote interdisciplinary debate and learning for the benefit of all of our patients. So please be ready with your questions. You can either type these into the chat function or use the Q&A function. Either is fine. And we've set aside quite a long time at the end of the, after the talks, so you get plenty of opportunity to grill the expert presenters. So, as our first speaker today, I'm really delighted to introduce a friend and long-term colleague from my own specialty of dermatology. Sinead Langan is Professor of Clinical Epidemiology at the London School of Hygiene and Tropical Medicine and a Wellcome Trust Senior Clinical Fellow. The title for her short talk this evening is Multimorbidity in Chronic Inflammatory Disease and Epidemiological Perspective. Thank you, Sinead.
Hello. As doctors, most of us are familiar with multimorbidity and know that it's common amongst our patients. But we may not know the extent of the problem. It's estimated that 50% of patients who present to general practice or who are admitted to hospital have multimorbidity. And the problem is that the way our healthcare system is set up, we tend to focus on our own disease areas. So I tend to focus on the skin, and Iain tends to focus on rheumatology. But if we don't join the dots between those specialties, our patients with multimorbidity may not be getting the best care. So today I'm focusing on the question as to whether chronic inflammation leads to multimorbidity. And this is important because if chronic inflammation does lead to multimorbidity, we should be targeting that chronic inflammation. And the perspective that I'm taking today is from an epidemiological perspective. We're interested in who gets sick, why they get sick, and what can we do about it, but looking at groups of patients rather than cells or molecules. So given that multimorbidity is so common, why don't we know very much about it? And I think the problem really is here. It's this focus on individual diseases rather than on the entirety of the burden. But also, people with multimorbidity are often excluded from clinical trials. And what that means is that for the patients sitting in front of us, they may not be at all similar to the patients that are in the clinical trials. Now, before I start to answer this question, we need to think what we mean by multimorbidity. I think conceptually we all understand or think we know what we mean by multimorbidity, but this seminal report from the Academy of Medical Sciences highlighted that there was a problem, that there was huge variation in the definitions used. And why does this matter? Well, if we all use different definitions, essentially we're comparing apples and oranges, and we won't be able to combine those studies in meta-analyses in order to inform clinical guidelines and improve outcomes for patients. So the definitions that are used, sometimes they're right across the life course or at a single point in time. Sometimes they include different diseases, they count the number of diseases, or they have a composite score. Helpfully, the Academy of Medical Sciences has proposed how we should define it. So it's the coexistence of two or more chronic conditions, one of which could be a physical condition like cardiovascular disease, a mental health condition like depression, or a chronic infection like HIV. So now, having defined multimorbidity, let's think about inflammation. Now, all of us experience inflammation. almost on a weekly basis. It's a normal physiological response to a whole range of different insults. But today we're focusing really on chronic inflammatory disorders. When you look in the literature, much of the evidence focuses on biomarkers of inflammation like C-reactive protein. And this is partly because those are really easy to measure. But the problem is that that may not capture the concept that we're trying to capture. Or studies focus on specific outcomes like cardiovascular outcomes, but that's not really addressing multimorbidity. The next problem is a really knotty one. Does the inflammation lead to multimorbidity, or does the presence of those multimorbid conditions lead to inflammation? And that's a trickier problem to address. Now, I'm going to focus next on an exemplar condition, and I'm focusing on atopic eczema because it's the one I know most about. But really, you could have substituted another chronic condition. Atopic eczema affects 1 in 10 adults, and our group and others have shown that atopic eczema is associated with a wide range of different health conditions, and that those associations get stronger as the disease is worse. The problem with this, from both a research and a clinical perspective, is that that's focusing on a single disease and a single outcome, and not on multimorbidity per se. We've also looked at it in GP data to look at multimorbidity specifically. I'm going to talk through what this slide means. So in this GP data, we've looked at groupings of disease from respiratory disease, mental health, skin disease. And if you see a line between two circles, that means that you have a 30% probability of having one disease given that you've got the other disease. And what we're looking at here is adult men with eczema and adult men that don't have eczema. And on the right, we're looking at the same for women. And we see similar patterns for asthma. And what we're seeing here is we're seeing a suggestion of clustering, which is suggestive of the presence of multimorbidity. There are two problems with this work. One, it's cross-sectional. The second problem, of course, is that people who go to their doctor with eczema might be systematically different from people that don't go to their doctor with eczema. And that's true for other chronic inflammatory conditions as well. So moving from the specific exemplar and looking more at observational evidence per se, there's some nice work done on inflammatory biomarkers. And I thought this study from Fabry et al. Was really nice. This looks at interleukin-6 levels over time. People in the black line have normal interleukin-6 levels at baseline. People in the red line have higher levels, and people in the dashed red line, their IL-6 is high at the start and it increases more rapidly. And what we're seeing is that at each age, we see an increasing number of chronic conditions, the higher your IL-6 is. So far in the observational evidence, we are seeing associations between chronic inflammatory disorders and multimorbidity. The key question, though, is this likely to be causal? Or is it likely to be explained by differences between the people with the inflammatory disorders and those that don't have it? So really a confounding problem. And that's tricky to address in observational evidence on its own. So let's use a bit more different type of information. What about genotypes? They're randomly allocated, and some people inherit pro-inflammatory phenotypes. This literature has been recently reviewed in systematic review, and what they've said is that there's no causal support from Mendelian randomization studies for race CRP, but there is some suggestions of causal links between IL-6 and cardiovascular outcomes. What other approaches reduce confounding? Well, randomized controlled trials are a really good way to address that problem. I couldn't find any good examples of trials of anti-inflammatory drugs to prevent multimorbidity, but we do see improvements in depressive symptoms in trials of anti-inflammatory agents. And this really nice work in the cardiovascular literature led to great excitement. This is the canakinumab trial, a secondary prevention. And what we're seeing here in people given canakinumab is a 17% reduction in major adverse cardiovascular events. Now, this led to huge excitement and to lots of additional research. The subsequent study, looking at low-dose methotrexate, which is cheap and readily available, showed absolutely no benefit. But there were some key differences between the studies. In this study, the CANTOS study, the inflammatory biomarkers were elevated at the start and reduced during the trial. In the methotrexate study, the biomarkers weren't elevated and didn't change during the trial. So let's bring all of this evidence together. In observational studies, we do have consistent evidence that inflammation is associated with multimorbidity. In the genetic studies, there's some suggestions of causal links with IL-6, but not CRP. And in the trials, what we're seeing is a modest evidence of some secondary prevention with a reduction in inflammatory biomarkers. So we don't really have the answer to the question as to whether chronic inflammatory conditions lead to multimorbidity. What do we need to do to get this answer? And really the key answer, and one of the reasons I'm so excited to be here today, is that we need to triangulate evidence from the type of work I do in observational epidemiology, with mechanistic data some of you do, genetic data, and trial data. But not only do we need to combine forces from a research perspective, but we need to also think about more holistic care for our patients in order to reduce suffering and improve outcomes for patients. I'd like to finish off by thanking Sara very much for the invitation to come here today, and the Association of Physicians for Great Britain and Ireland for the opportunity to present at the seminar. I'm looking forward to some great discussions. Thank you.
Thank you, Sinead. It's a wonderful overview and lots of food for thought. So next up, I'm going to invite Simon Jones, who I'd not actually met before this seminar, but he came very highly recommended by several of the AOP ExCom. So I was really delighted when Simon accepted the invitation to speak. Simon Jones is Professor of Inflammation Biology and Co-Director of the Systems Immunity Research Institute in the School of Medicine at Cardiff University. And his talk this evening is entitled Cytokines as Architects of Inflammation. Thank you, Simon.
Well, thank you, Sarah, for the invitation. It's really great to be here. And as a basic scientist, it's fantastic to have the opportunity to talk to clinicians about mechanisms of disease and inflammation, and to try and show some of the links that Sinead was talking about relating to cytokine action and inflammation, and how we can understand their biology and how they are interpreted in disease settings. So I think fundamentally it's very important to understand the mechanisms by which inflammation is controlled, particularly in very defined clinical settings. The importance of these factors such as cytokines are really instrumental in directing the kind of rate of disease progression, the influence on the disease outcome, and also the kind of response to therapy that we see, particularly in diseases which may be highly heterogeneous and are very complex, particularly in our immune-mediated inflammatory disease scenarios. Now, the first thing to think about when we look at inflammation is that it's not a disease, but a consequence of disease, and is very much a tightly organized communication system that relies on the kind of network of responses that are mediated between both stromal tissue cells and immune cells that may be both resident to that inflamed tissue or equally are recruited as part of the disease process. In order to initiate this communication, we now have a body of proteins which are regulating this intercellular communication. I've listed a few over here. The interleukins, for example, defined by their ability to communicate between leukocytes. Interferons, very much instrumental in controlling antiviral responses. Chemokines, which are linking the ability of immune cells to be trafficked to sites of disease. And we have other players within TNF superfamily and growth factors, which are mediating responses, controlling cellular proliferation, expansion, immune activation, etc. So fundamentally, with these players, what we have is an ability to sense and interpret the inflammatory environment in which they sit. Within the local compartment, these mediators may be controlling responses in cell types that are specifically expressing surface receptors that are required for interpreting these cytokine mediators. So there is an involvement here of both factors which are involved in sensing the cytokine environment and also inside the cell mechanisms which are responsible for interpreting in the way that those factors are initiating cellular responses that are directing the cell response. Now, of course, as a consequence of much research. We now have various biologic drugs which are in clinical application, which really interfering with the sensing mechanisms, the outside compartment, either targeting the cytokine itself, the receptor. They may be using different approaches such as soluble interleukin receptor antagonists or factors which are directed against multiple cytokine actions. So these are really complex mediators. Whether there's an advantage of blocking a cytokine over a cytokine receptor, for example, is in much debate. But these show varying degrees of pharmacokinetics and pharmacodynamics, which influence the way they are used. Importantly, we also have small molecule interventions. The JAK kinase inhibitors is a classic example down here, which very much interfere with the interpretation. They act inside the cell and disrupt the way the cytokine signal is perceived. So there has to be a way in which we can kind of think about these and how best to apply these agents, because we know from clinical experience that some of these agents work better in some particular clinical conditions, and also they also work better in some individuals more so than others. So the importance of that is really emphasized by the fact that cytokines are instrumental in our normal physiology. They contribute various activities which are linked with our normal physiology and well-being. And these are really hierarchical, because we can also see examples of cytokine systems in both fruit flies, where their roles are in regulating things like metabolism, development, for example, the wing, for example, or eyes. We also see them involved in controlling fly innate immunity and general tissue homeostasis. We also have a bunch of data which comes from genetic studies in mice. And while a lot of work is fundamentally focused on the generation of animal models of disease in mice, some of these do not necessarily accurately reflect the situation that we see in humans. But under basal conditions, the phenotype of these cytokine deficient mice actually provide us with real insights into what the cytokine may be doing in health. Now, if we go into humans, we can really see that cytokines have very much instrumental roles in performing activities that are linked to all aspects of our physiology. These range from looking after our barrier immunity at surfaces such as skin or within the gut or within the lung, but are equally important in determining aspects including bone turnover, our liver function, vascular biology, of course, and it impacts on things like muscle and adipose tissue. And it's important to remember that cytokines are often defined as being adipokines or myokines. So these are kind of linking the biology to very particular functions. And of course, with the introduction of biologic drugs and small molecule inhibitors that are now widely used in immune-mediated inflammatory diseases, we can see that these agents are having far-reaching impacts on our physiology, including impacts on fatigue, for example, through control of anemia, or it may be impacts on pain and physiological processes affecting our mood, fatigue, depression. These types of things are very much instrumental there. So we can see then that there's a very tight relationship between these factors in both the development and control of normal healthy physiology and the progression of pathophysiology and disease progression. The questions are then, how do cytokines then transition from this protective state into something which is much more detrimental? And can we use our understanding of cytokine biology to better predict the way in which we apply therapies or target particular cytokines under particular circumstances? So I think there's a kind of a need to really understand the roles that cytokines play in disease. We actually very often talk about the development of the cytokine network within pathology, whereby we recognize that various different factors are coming together in a very coordinated or perhaps uncoordinated way to initiate processes that regulate the outcome of disease. So what I've done here is classified in a kind of an arbitrary way. I've kind of made it up, if you like. I've listed a series of cytokines at the top and then assumed particular activities that are relating to their involvement within that particular pathology. Now, these are often related closely to the ability of cytokines to regulate local inflammatory mechanisms, which are responsible for driving tissue-specific disease. But we also have to remember, as alluded to by Sinead, that the cytokines are also contributing to systemic outcomes, which may be including, I've listed here, alterations in lipid metabolism and vascular function. But these are aspects which are broader than perhaps the pathology itself and may link it to multimorbidity, for example, as a classic example of where we think cytokines are regulating. So perhaps there is a need to break inflammation into two compartments, one that is driving the local reaction and another which is much more instrumental in coordinating systemic responses, which may be common to a variety of immune-mediated inflammatory diseases. So obviously then if you transition this kind of profile that I've kind of engineered here, we can then think about other disease scenarios. And of course, within these particular settings, the patterns of involvement particularly shift. And these patterns of involvement may then give us insights into how we should be targeting cytokines selectively within particular diseases. So what that's resulted in is this idea that cytokines form an archway within the kind of immune response to the disease. And the arrangement of these cytokines within this archway is important and instrumental in driving outcomes. That leads us to this idea that the keystone at the top of the archway is fundamentally important in holding up the whole cascade. And by targeting this particular cytokine with therapies, which may be small molecule inhibitors or biological drugs, we may be able to more appropriately crash the inflammatory reaction and bring down that disease response. That's a challenging aspect to understand, and perhaps we need to put that in context a little bit. So what I've tried to do here is use interleukin-6 as an example cytokine, whereby we know that therapeutic interventions are successful in some clinical situations, but are less so in others. And what we've got here are three stone archways representing the cytokine network in three different disease settings. In the first instance, interleukin-6 sits at the top in terms of that keystone position. These may be diseases such as rheumatoid arthritis or juvenile idiopathic arthritis, where we know that interventions of interleukin-6 are successful and certainly can combat disease in a proportion of the patients that receive these interventions. In this particular case, targeted intervention will then crash the stone archway and bring the inflammation down. In settings such as psoriasis, interleukin-6 may still be part of that inflammatory process and is instrumental in driving aspects of the disease, but it certainly may not sit in that keystone position. And instead, maybe a factor like interleukin-17 with the success of secukinumab, really illustrating that targeting IL-17 is a much more advantageous approach to crashing this particular stone archway. The third situation is a little bit more complex in a sense, because in these particular diseases, we have the stone archway that is set up that is responsible for driving the disease. Interleukin-6 may sit at the top of this particular archway here in its keystone position. But what we also know is that under normal healthy physiology, interleukin-6 is important for controlling normal physiological processes, for example, barrier immunity. Now, this could be relating to ectopic dermatitis, which I'll give you an example of now, but it could equally relate to contraindications which are associated with IL-6 intervention. These include gastric complications such as diverticulitis, where interleukin-6 is important for gastric, for turnover of the regeneration of the epithelial surface. But in atopic dermatitis, trials with IL-6 interventions such as tocilizumab showed that the intervention was effective in limiting the development of dermatitis. But as a consequence, what we also saw was an increased interference of barrier immunity, resulting in increased episodes of skin infections as a consequence of that intervention. Now, in this particular context, it would be interesting to look at the genetics associated with this, because we also know that conditions like Jones syndrome and patients who have autoantibodies that are regulatory of IL-6 activity these patients show episodes of skin infections on barrier surfaces. So perhaps this particular application or this converse outcome should have been predicted if the biology had been considered in greater detail. So how can we think about that as a future? And this is my last slide. And I'm really trying to think here about the way in which we have to view not only the way in which we measure cytokines as markers of inflammatory disease. We've already heard that interleukin-6, for example, correlates with cardiovascular outcomes and such like. And these factors are really now giving us a marker, but they're not really telling us very much about how cells are interpreting those decisions. And can we use now more holistic approaches to kind of look from the outside of the cell to the inside of the cell? Perhaps think about the genes that are being orchestrated, that are regulated as part of that cytokine network. Perhaps thinking about genes that are controlled under therapy, for example. What are the response to therapy indicators that we can see? And use this information to not only understand local pathologies, but also to think about the relationship of what happens within the blood and how that may be reflecting what happens within disease settings as a whole. With this information, using cutting edge technologies which now are available, including transcriptomic and epigenetic analysis, but also that could involve proteomics and metabolomics, we may be able to combine better information to improve not only the diagnosis, but more importantly, the stratification of those patients to allow better treatment decisions and ultimately improvements in disease outcome and perhaps drug-free remission. And I'll just leave it there. Thank you.
Thank you, Simon. Again, an amazing overview in 10 minutes of what is a very complex subject. So I've been writing down lots of questions for the discussion. But before that, we've got our final talk this evening. Last but not least, I'm delighted to introduce Iain McInnes, who, as many of you will know, has a wealth of expertise in the use of biologic therapies as a rheumatologist. Iain is head of the College of Medical, Veterinary and Life Sciences and vice principal at the University of Glasgow. And Iain's talk today is called Deconstructing Immune Diseases to Optimally Choose New Therapies. Over to you, Iain. Thanks.
Thank you very much indeed, Sarah. Very kind of you. And if all goes to plan, you'll be looking at a picture of Adam Smith and the very, very nice wallpaper and carpets that lead to the principal's office. I can assure you my office looks nothing like this. So listen, what a joy and a pleasure to share a webinar with such esteemed faculty and chair. And what I want to do in the next couple of minutes is think a little with you about how we might deconstruct these extraordinarily interesting, fascinating, but devastating complex clinical conditions that involve many organs. And we heard beautifully depicted the concept of multimorbidity, organs even within a disease, but beyond that disease constellation. And that's really what I'm going to focus on in the next couple of minutes. These are my relevant disclosures because I'm very bad and I work with all sorts of interesting people and I have been lucky to be funded by all sorts of interesting people. So thanks ever so much to them. My children are very grateful. Right, so let's start with rheumatoid arthritis. Terrible disease. A disease, however, that was driven for many, many years in terms of therapeutic intervention by fear of drugs rather than fear of disease. Now, back in the early days, we treated this immunological catastrophe, destructive disease with up to a decade of loss of life expectancy with potent medicines like aspirin and brufen. And obviously half a century or so ago along came glucocorticoids. And then it took another half a century at least before we had the advent of cytokine blockade, so beautifully introduced by Simon just a few moments ago. And with that, a cascade of new therapeutic interventions. These interventions, I want you to think of them, please, as molecular scalpels. They bring about the possibility, pioneered by the TNF blockers, of exquisitely targeting one part of the immune response. And the key advantage here being that we can take out one part, leaving host defense nominally intact. And these were the pioneering molecules, the class of drugs that were the TNF blockers. A whole range of these are now biosimilars alike. And then they were applied beyond rheumatoid to a range of different immunologically mediated disorders. But I want to make a really important point here and use TNF blockade as the exemplar. TNF blockers work beautifully in psoriasis, psoriatic arthritis, axial spondyloarthritis, and rheumatoid, but they made multiple sclerosis worse. They were beneficial in some forms of IBD, had pretty minimal impact in lupus, Sjogren's, and scleroderma. So simply knowing that inflammation is there and that a cascade of abnormality is present is not sufficient to predict whether a medicine is going to work or not. And actually that early pioneering work led to the application of immunologic targeting medicines, biologics, mainly targeting extracellular cytokines introduced, as I note, by Simon, or the membrane receptors that subserve the functional biology of those cytokines, or nowadays we can move inside the cell with really rather specific medicinal chemistry to take out different kinases, the Janus kinases probably being the best example at the moment. And so a range of immune disorders, the so-called immune-mediated inflammatory disease class, now amenable to broad therapeutic intervention. Of course, what is not contained in this slide of perfection are all the imperfections, all of the failed phase 2 trials where we inappropriately applied a medicine to a disease based on an imperfect understanding of disease pathogenesis. And what is not also, I think, appreciated sufficiently is that we, despite an extraordinary 2 decades of progress, and let's celebrate that, but look, I'm Scottish, the glass has got to be half empty, so we're not in remission nearly often enough. We don't repair the tissues, and we very rarely achieve immunologic homeostasis. So being Scottish and grumpy, I often enjoy the beautiful book from Charles Mackay, and this is one of my favourite quotes. Do you have a favourite saying? Asked the boy. The book depicts a notional conversation between, well, you've got it, a boy, a mole, a fox, and a horse. I love this one. Do you have a favourite saying? Asked the boy. Yes, said the mole. What is it? If at first you don't succeed, have some cake. I see. Does it work? Every time. So you see, what we've been doing with this immunological cascade of events is to choose new medicines at the expense of thinking about how we actually need to take on these complex immunologic disorders and their and multimorbidities. Those are different things, by the way. So I don't think we understand the underlying pathogenesis well enough. We're still defining diseases by the organ of involvement rather than the mechanism that drives the organ's involvement. We don't then trial drugs particularly smartly. We don't combine drugs rationally. We combine them on the basis of existing active therapeutics. And then we don't revolutionize the strategic use of these incredible medicines now available to us, seeking immunologic homeostasis. We should be thinking about remission and cure as the base case for the treatment of immune-mediated inflammatory diseases. Now, is that fanciful? Is that out of reach? Well, I would argue that it isn't. I would argue that in this age of exquisite molecular resolution at the cellular, now the subcellular level, and within tissues, we have the advent of single cell sequencing, where an individual cell gives up its mRNA secrets to the rather complex immunoanalyses that we can do rather routinely nowadays, but then with a bioinformatic black box that defines what molecules are present in which cell and where now in the concept of spatial transcriptomics. We can look at biopsies and work out what cell is actually doing what, and from that combine these bits of information into a cellular atlas that capitalizes on what was kicked off a couple of decades ago in the Human Genome Project. Simon alluded to this concept, or about understanding the base case, the genetic epigenetic rationale for immune disease, building on that an understanding of what tissues do could potentially lead to a resolution of molecular complexity. In a sense, these methodologies allow us to deconstruct complex disease. Now, this is an essay that George Shedd and I wrote last summer. And what we've done here is we've depicted a notional idea of rheumatoid, ulcerative colitis, Crohn's, psoriatic arthritis, and axial spondyloarthritis. Sarah, I'm ever so sorry that atopic dermatitis is not in there. It's a heinous offense. Sinead will have her revenge momentarily. But go easy on me here. The editors were a little restrictive in space. But what we've done here is we've thought about this less from the organ-based perspective and much more from the pivotal cytokines that drive these diseases. In a sense, moving from the top concept, which is organ-based diagnostics. This is what we teach our medical students, the diseases of the gut, the diseases of the joint. But actually, when we think about it, that is mechanistically unsatisfying. Because we now know that, for example, in a patient with psoriatic arthritis, if I give them an IL-17 inhibitor, their skin and joints and axial skeleton may do rather well. If I give them an IL-17 inhibitor and they also have GI disease, their gut disease may get worse. In other words, we can no longer predict which organ across which disease state defined by organ alone will in fact respond faithfully to a given cytokine inhibition. Much prefer then that we move to a signature inflammatory hub model. Now, how would we do that? Well, this is an idea of how we might deconstruct diseases. We would take on the top of this figure a range of different potential candidate pathways. The kinome, that's the 518 kinases so far described in the human condition. And we may just look at them all, or we may look at specific candidates. We can think of cellular therapies, particularly regulatory T-cell based therapies. And we use those to deconstruct disease and then combine that with regenerative medicine possibilities. And that, taken together, will allow an enhanced drug discovery process. Now, we're going to use that, Sinead, I hope we'll be delighted to see that electronic health records and large-scale population genomic and population clinical follow-up. Equally, I do hope Simon will be happy to see that we are very much focused still on using the complexities of the inflammatory cascades that he described for us. And that in turn will allow in silico medicinal chemistry and in silico trialing to occur long before a human being is exposed to a new experimental medicine compound. And we will therefore do our trials with a higher degree of confidence that we can seek immunologic homeostasis, immunologic tolerance, and immunologic repair. And actually, if you take this deconstruction far enough, ladies and gentlemen, you'll realize that we're seeking not only to deconstruct our diseases, but also our ologies. I am going to put to you, maybe a little controversially for a Tuesday evening, that we probably don't want gastroenterology, dermatology, and rheumatology. We want imidology. So we meet together on a common platform with common possibility and common construct. And with that, ladies and gentlemen, I suspect we will change lives. Just as a final thought, these are the amazing kelpies, fabulous. Look at this, they're enormous. They're about 20 or 30 meters high. The kelpies, the Scottish water ghosts, they only come out at night and quite often after you've had a glass of something interesting. You may well be on the right-hand side laughing away, or maybe just I've caught your attention on the left, thinking carefully about whether deconstruction is the new future for reconstruction of our patients. Thanks ever so much for your attention.
Thanks, Iain. Well, of course, we have to forgive you for not including the most important organ in your review, the skin. However, it was still incredibly interesting and certainly fits the remit for thought-provoking. So just to encourage again, any of the people that are out there watching, if you'd like to submit questions, you can type them in the chat or you can put them into the Q&A. And if you'd like to speak live, then just raise your hand. Well, I'm not sure if that's allowed actually. Put your questions into the chat and we'll read them out. But I've got plenty of questions to start off with, and I'll take the chair's prerogative to do that. So this is a question, I guess, to all of you really, but raised by something that Iain said. So Iain, you're optimistic that with our increasing understanding of molecular mechanisms, single-cell analysis, spatial transcriptomics, we're going to be really able to aim for cure, disease resolution and persistent resolution. And I challenge you to convince me, because from what we see of biology, there's such a fine balance, isn't there? And Simon highlighted this very much, and Sinead's highlighted the complexity as well. So I totally get that we can correct some of the inflammation, But we see in many examples throughout clinical medicine that if you correct one type of inflammation, you unbalance the other type. So how can a greater molecular understanding help us with that bigger picture of the seesaw effect that we struggle with in immunology?
Yeah, it's a great remark. So let me make a start. For simplicity, we tend to show the immune response as the pathogenesis of a disease. But what we should really do is we need to add the critical issue of time in there. The second, and the problem is that most of the immune diseases that we treat are really late stage, immunologically speaking. And by then a whole series of interactions have started to occur. Damage to the target tissue, damage to the target tissues, plural. And then, Sinead made the point beautifully that the immune-mediated inflammatory diseases actually share a whole range of comorbidities, often occurring more than once in a patient, and therefore by definition multimorbid. And I think if we were to go back to the defining moments when those very early phases of intervention become possible, and that's the concept of pre-disease, which we're all over that in rheumatoid arthritis now with RA defined by autoantibody positivity and nothing else. Now we can argue about when the disease starts then. But I mean, us rheumatologists are even pretending that psoriasis is pre-PSA. So dermatologists are basically pre-rheumatologists, which is a kind of a nice evolutionary progression for us if we wanted to be really naughty. But I'm only kidding, of course, but that's the joy of virtual webinars. I can be rude without fear of harm. No, you know where I'm going with this. So I think, first of all, the concept of kinetic, if we get in early enough and we can manage the multiplicity of pathways that are eventually driving established disease, which you're absolutely right, sit in imperfect balance. And therefore you are then at the risk of, the classic thing is you give a Th1 inhibitor and you get a Th2 disease, but actually that doesn't happen as often as we think. I also have to say as a final remark that I'm not really a believer in diseases as a precise end of one part of the immunological balance. When we really go in and examine the complexities of the disease, we discover that that's a very poor description of our patients indeed. But I'm optimistic, very early intervention, we can establish homeostasis before, if you like, the seesaw becomes too complex and overloaded.
Well, that is very optimistic. Simon, what do you think? Do you agree with that optimism that if we intervene early enough, we can really get a handle on disease?
Yes, I do. I think what we actually see in certain circumstances is that there's evidence that if you have a repeated or recurrent inflammatory episode, that exacerbates the whole process. It's almost like sending everything out of a tailspin. You're creating a problem on top of a problem. So by working right the way back to that initiation step as soon as you can, and identifying whether a patient is likely to progress in that way gives you real opportunities to control it. Now, whether that reflects what happens in terms of local pathology versus systemic pathology, that's a different situation. But I think that there is real opportunity there for early intervention to kind of give us a relation opportunity.
And are you talking about disease prevention, or are you talking about ultra early treatment of a very nascent disease?
Yeah, a little bit of both, I think, in ways. You have to try and establish, for example, if there are genetics giving you a predisposition of something, then understanding what that genetic susceptibility is may give you opportunities there. So yeah, I think so.
You're probably aware we've tried it in dermatology, so we have a very good handle for genetic risk for atopic dermatitis in terms of skin barrier impairment. And there have been several large-scale clinical trials now to intervene very early to enhance skin barrier that sadly have had no impact on the incidence of atopic eczema, and that's starting barrier enhancement within days or weeks of life. So I guess, you used atopic dermatitis or atopic eczema as an example of a disease that really is very complex. And that was my conclusion from those clinical trials, that, we think we understand skin barrier to a certain extent, but actually there's a lot that we don't understand. And early intervention could be even in utero, or certainly, so early that it's it's challenging to implement from the perspective of atopic eczema. Maybe I can bring Sinead in. From the epidemiological studies, do you get clues for how early we might need to intervene in order to truly switch off or prevent inflammatory disorders before they reach this vicious cycle that sets up a very unstable seesaw? What can we learn from epidemiology, Sinead?
And I think we don't necessarily have the answer to those questions. I think the question's a really good one as to whether early intervention really switches it all off. And I know there's work ongoing, there are registered trials to answer those questions. I mean, to a certain extent, some of the morbidities that you see in people with very severe chronic inflammatory disease, like atopic dermatitis or rheumatoid arthritis, who might have had extensive oral steroids, for example, and adverse consequences of those treatments. I mean, you can imagine that you could potentially switch those off if you effectively treat the condition. But as to quantitative evidence to kind of support it, I like a little bit more evidence. But I can totally imagine conceptually that would be, with some of the morbidities would certainly be.
Yeah. Oh, thank you. So there is actually an epidemiological related question I'll just read out from the chat. So this is from Ernest Choi. Thanks, Ernest. He said, complete skin clearance is feasible with new biologics in psoriasis. Is there evidence that multimorbidity is less in these patients?
There's a lot of work ongoing. So Joel Gelfand and others are leading a lot of work with trials focusing on systemic outcomes in people treated with these agents. For example, Simon referred to secukinumab, and Joel has also done some work on Premolast and other agents and looked at various aspects from aortic inflammation right through to metabolic disturbances. And there are certainly some signals from some of those trials showing reductions in aortic inflammation, for example. So far, the work is still in early phase and there's more work planned, but I think there is some hope from quite a bit of that work that Joel is leading, to suggest that targeting that the skin may have other benefits.
But presumably those are not very early intervention. Those are, by definition, potentially relatively late intervention if it's quite aggressive treatment of established psoriasis. Yeah. Okay.
Can I just add to that? Ernest, it's a fabulous question. Because there's an additional subtlety. So Sinead's absolutely right. We're in the early days, but I mean, Joe Gelfand and Neil Mehta at the NIH have done some beautiful imaging studies to try and look. And what we do know is that an immune-targeted mechanistic intervention will lead to a target tissue reduction in tissue damage. So you get PET abnormalities are normalizing when you give biologics to people with psoriasis. What's really, really interesting, and I thought you brought that out beautifully, Sinead, in your presentation, we don't know about directionality yet. So there's some really interesting Mendelian randomization suggesting that actually adiposity is causative in psoriasis. Now that turns, so that's where, Ernest, I love the subtlety in what you're saying here, is the magnitude of clinical response achieved associated with greater reduction. Well, let's call it comorbidity because it doesn't really address the multimorbidity issue that Sinead highlighted earlier. Now, I think actually, again, I'm becoming ridiculously optimistic. I need to chill a little bit. I actually think we do see evidence that the magnitude of improvement in some of the surrogates, the biomarker surrogates for cardiometabolic risk, actually are more likely to be normalized in the context of high hurdle responders. So, Ernest, we're not quite there in terms of the hard outcomes, as Sinead points out, but I think the early surrogates of risk are going absolutely in the right direction. But just a commentary to that, if the fundamental derogation or challenge is, for example, skin barrier function, then we may need to think differently across different immune diseases. So it might actually be the fundamental challenge that atopy or atopic dermatitis poses is actually fundamentally different from an underlying immunologic dysregulation that keratinocytes will perpetuate in psoriasis. So once again, this is why the deconstruction model for me is so attractive, because it does away with that conception that everything has to be the same.
Yeah, no, I fully agree. The complexity is requiring deconstruction so we know to target the right thing. That brings me to another question that I can maybe posed to both Simon and Iain. So Iain quoted the biologics as molecular scalpels, whereas Simon used these beautiful stone arches. I want to know if you built those stone arches, Simon. But Simon's concept was remove a stone and the whole arch breaks down, which seems to be the opposite of a molecular scalpel that's very specific and targeted. So what do you think we're aiming for, guys? Do you think we need to destroy the whole stone arch, or do you think we need one very specific scalpel? You choose who goes first.
Simon, why don't you go first? Because every time the Scots go up against the Welsh, the Scots get hammered. So why don't you go first, and then I'm gonna deconstruct the archway if I can. We'll see how this goes.
Okay, this is good. Okay, so my view is that that cytokines sit in a network, and they have clear interactions with one another, and they shape decisions. They're interpreted in a particular way, and they have a connection with each other. Sometimes they're distal connections. Sometimes they do completely opposite effects, and sometimes they're kind of synergistic and working together. So I think that the archway gives you an understanding of how cytokines connect with one another. It's about thinking that inflammation is not just about one particular mediator, but that particular mediator may be directing a very positive response under normal physiology. But when it suddenly partners up with these teenagers hanging around underneath street corners with cigarettes and such like, they suddenly start, doing naughty things, and they end up giving you, tissue damage, tissue injury, and inflammation. So for me, it's a way of allowing you to understand that there is an interconnection between them, and that you have to kind of play to that a little bit in order to understand the transcriptional mechanisms that are being interpreted in order to direct it in one direction or another. And that's for me the way it works. But
the network. Okay, over to you, Iain.
Yeah, Simon, so I actually agree with that. I think the archway is a useful dichotomous approach to whether you want to go in to do a clinical trial or not. So if you want to take a molecule out, you've got to believe that by taking that molecule out, the archway of disease will collapse. However, what we're really aiming for, and by the way, the molecular scalpel, I don't think is in contradistinction to the archway. Just for the record, the molecular scalpel is that we go in and we know for sure that a biologic against TNF is only going to inhibit TNF alpha. Now, the reason I think that's a really important distinction, because a JAK inhibitor, a Janus kinase inhibitor, will inhibit maybe 5 or 10 different cytokines, and depending which one it is and which JAK subselectivity it has, that might make quite a bit of a difference. So I think the scalpel argument holds up and is not actually in contradistinction to what Simon's saying. But what I would say is that I actually prefer a network than an archway, because what you want to do when you're going in therapeutically is take out that part of the response that is essential for disease to manifest. And you need to reduce that to its lowest common denominator, leaving as much of the rest of the functioning host defense response intact. So it might not be a two-way arch, it might be a quadrupod or a quintupod or something, and you have to get in there to the bit that is absolutely essential for disease. So the disease collapses, but host defense doesn't. Now that actually... Sorry, I'm going to be boring here, but that's why embracing the complexity of disease rather than shying away from it that's our privilege in the future. We didn't have the methodologies to do this in the past. We had to be quite binary, which is why the archway is a beautiful model to go, no go if you've got a medicine in your hand. In future, I think our patients deserve a much subtler synthesis of what is going on in the disease, kinetically, and for that one individual, thinking of the complexity of their background genome and, more importantly, epigenome. So just a few thoughts. I'm going to say Wales won that by a point, but it was close, which is about as good as the Scottish rugby team ever gets these days.
Wouldn't dare to disagree. We've got some patient questioners on the Q&A, so I'll read out the next one. This is from Matthew Griffin. Matthew says, very interesting presentations. Can any of the speakers give their thoughts on the role of cellular senescence and so-called senolytic agents in multisystem inflammatory disorders? So I must say that's a new one to me. Who'd like to comment on cellular senescence and senolytic agents?
I'm happy to start there. It's a brilliant question, Matthew, if I may say. So first of all, there's quite a bit of evidence of cellular senescence in people with immune-mediated inflammatory diseases. I'm probably most informed in the rheumatoid area. I'd refer you particularly to the work of Connie Wayand and others if you're interested in this in the West Coast. What is less clear is the causality as opposed to association here. And a kind of take-home summary for those who don't live in this slightly odd immunological world of ours, people with rheumatoid arthritis are actually biologically a lot older than they are chronologically. And that has its origins partly in having chronic inflammation and partly actually in some of the background HLA genetics that are associated with your likelihood of getting rheumatoid arthritis. As to the best of my knowledge, senolytic therapeutics are being thought about, but so far I've not seen a positive trial outcome with their application. But I'm always very happy to be contradicted, but I haven't seen those data. We have seen one or two interesting data in other diseases, osteoarthritis, for example, and I'm not sure those in the public domain as yet.
Is it possible to tease out the difference between a degenerative disorder of aging in cells as opposed to a more specific, what might be a senolytic effect that you need to target?
That's a great question. It probably is if you're an expert in senolytics, which I amn't. But I think the idea of what is a degenerative disease is probably a subject for another AOP webinar, because we used to think of OA as degeneration, whereas actually it's that osteoarthritis isn't. Osteoarthritis is something to do with maintenance of repair. It's something to do with inflammomechano responses and. So I don't know if we're ready for that level of dissection. So it's a great question.
The reason I asked is because some of our diseases do burn out with age, don't they? So atopic dermatitis would be an example, but I know rheumatoid arthritis can burn out, or that's what I was taught when I did rheumatology. So that's kind of the opposite of an age-related thing. It's an age-related improvement in disease. So something that we'd like to. I feel like if I could bottle natural resolution of atopic inflammation, that would be incredibly useful. We've got another 2 questions in the chat, so I'll press on. So Anne Ager has said, can we learn anything from cancer patients on checkpoint blockade inhibitors that develop apparent autoimmune conditions? Are these conditions like real autoimmune disease? So Anne, I'm going to take the opportunity to plug future AOP seminars. We are going to have at least one, possibly a series of seminars on exactly these kind of questions of immune checkpoint inhibitors and targeting the immune system in cancer. So if I may, because we've only got 2 minutes left, I'm just going to jump over to Adnan Kustovic's question. So he said, disaggregation of complex chronic inflammatory diseases will require a genuine team science. Totally agree with that. However, what we practice in medicine is selfish science with ongoing obsession with the first and last authorship, lead institutions, etc., etc. Forced to agree with that as well. There is no clear career pathway for data scientists, or maybe that's data scientists, and we're losing the best and the brightest to the tech and finance sector. How can we change the system and ourselves to facilitate these essential changes? If physics can do it, surely we can. So, I mean, that's a great question to end with. Sinead, maybe you'd like to comment first. Do you have any feel for the retention of data scientists and epidemiology is a prime example within clinical medicine, because that's surely what we need?
Yeah, thanks, Adnan. That's a fantastic question. I totally agree. That's a real challenge. We have fantastic data scientists, and I guess the current system means that potentially once they've learned fantastic skills, that university becomes less attractive because of insecurity of jobs and other issues. And I think perhaps we need to be a bit cleverer about how we structure jobs going forward, and maybe consider joint appointments between university and industry, for example. Maybe there is a big focus in Health Data Research UK on improving pathways for careers for data scientists. Is a big investment of effort in trying to negotiate and make those pathways more established. So I'd say it's a work in progress, Adnan. I don't think that we have the answer totally to it yet, but there's a lot of work ongoing. In relation to your first question about us focusing in silos and kind of being disincentivized from working outside our silos, I think that is true. I'm hoping that seminars like this push it forward. I guess some of the challenges are with systems. For example, this week we're all looking at our ref results, which I guess maybe focus a little bit on first, last authors, your own personal impact. So I think that there's more work to do there. I'd be interested in other people's thoughts.
Simon, you mentioned in your talk the importance of, you actually said you enjoyed speaking in a forum where there were clinicians. So I'd like to say something that I've observed retains people in clinical academic medicine is the interaction with great scientists. And that is something that we have as a great privilege that I think is sometimes harder to obtain in industry. So Simon, how do you perceive it in terms of career retention for key specialties or key expertise to gain this breadth of understanding across disciplines?
Yeah, I think it is difficult, and I totally agree with what Adnan's saying. There are challenges that you can see in terms of career pathways. We know that lots of us are based in medical schools, and then we have promotion applications that come in from data scientists, which we don't necessarily understand how is the best way of supporting them in terms of their career ambitions. What is the best way to showcase their skills and their dedication to the research that we're doing. So I think there's a little bit of work to do there. Maybe that requires closer connections with schools of mathematics and physics, etc., where these types of skill sets are more commonplace, I guess. I think the idea of working in silos, I hope that's breaking down. I'd like to think that the interactions that I had, particularly with clinicians and data scientists, has been very, very supportive and very interactive. And I think that as we get new technologies which allow us to dissect very complex cell biology, we really rely on each of us contributing a skill set, and it's about contribution rather than first and last author. There's always going to be a little bit of that going on, but I think we're moving in a direction where I'd like to see that being broken down more and more.
Great, so more optimism, Simon. That's good to hear. And I realise we're over time, but I'm allowed to ask one last question. So I'll put that same question to Iain. You've had a lot of opportunities to work with people at all levels and all disciplines, and obviously you're in a very senior position now. What's your perspective on this? What can we do to correct ourselves and improve for the future?
Yeah, thanks. It's a brilliant question, Adnan. It's nice to finish with a philosophical element. Yeah, different elements to this, aren't there? It's about the incentivization. So first of all, I believe that a large part of our science going forward will be society challenge driven. And society will therefore quite rightly require that we bring the best team to the question. Now, the ref is just in, but the ref was interesting this time. Impact, more important, and much less focus on ref adjudication of author order, provided contribution was appropriately justified. Now, if that momentum continues, and we hope it will, then the national level recognition that we as a clinical and scientific community are funded for the societal good will bear fruit. As to the idea of the first last author mentality, I think there's a huge responsibility on senior scientific and clinical leaders in this country to lead by example and make sure that younger investigators are brought through and occupy in part those conditions, but also look at the adjudication on the quality and contribution that people make. And if we can move away from that fixation to first and last to actually think about what people do and why what they did was so important, then we're in a good place. And that's why organizations like the Association of Physicians are so important, the Academy of Medical Sciences. We have a real responsibility to advocate on behalf of the knowledge base we will need to make a difference for lives of our patients in the future. that for me is worth doing. So with that, Sarah, I'm going to hand back to you. But we could go on all night in the subject, but what a great question to finish with.
Yeah, no, I agree. It's a rallying call, isn't it? We've got great responsibility, but great opportunities. And at the end of the day, it is for the benefit of our patients as well as our colleagues that it's a no-brainer. We need to work better together. So I will draw it to a close. Thank you to all the audience. I hope you've enjoyed this, either watching it live or watching the recordings. And I must say thank you again to our 3 expert speakers, both very engaging, very knowledgeable, stuck to time excellently. And we're so grateful that you've allowed us to record your talks. I know that's an extra ask that we put upon you, but we were very keen to do that to allow people that aren't able to attend at this sometimes difficult time of 5 until 6 o'clock on a Tuesday evening. Many more people will be able to watch in their own time. So thank you, and look out for future AOP seminars in webinars on a roughly monthly basis ongoing. Thank you.